Thanks so much, Jody, and really thank you very much for the opportunity to talk with everybody. Let me know if you can't hear me. We're going to talk about sort of a complicated topic. This is central sleep apnea and Cheyne-Stokes respiration. We are going to cover over the next 50 minutes or so pathogenic mechanisms, look at the clinical impact, and talk about how we recognize the problem polysomnographically and really nut out a therapeutic approach. So by way of disclosures, a number of different activities, but the ones of relevance are really those related to respicardia, where I'm involved with teaching activities, this one included, for both respicardia as well as zolidamar. And so this is one of my activities that I am compensated for. Again, thanks so much for your involvement. And what we're going to do really is discuss the pathogenesis of central sleep apnea and Cheyne-Stokes breathing. We'll recognize the polysomnographic manifestations and the clinical impact, and look really in detail at therapeutic approaches, which has been challenging to this point in time. Our organization, or our outline today, is really first to look at the pathogenesis, and we'll spend a little bit of time because I think there is an organized pathogenetic approach to recognizing the problem and nutting out the underlying mechanisms. We'll look briefly at the clinical impact. We'll talk about how to recognize this on sleep studies, high-level view, so that you're sure that you recognize the different patterns of central sleep apnea, and then talk about the therapeutic approaches. First, in terms of pathogenesis, I do want to mention, although this is not the primary focus of our discussion today, I want to mention the fact that really there are two types of sleep-related central sleep apnea or respiratory depression. One is sustained sleep-related hypoventilation with hypercapnia, and that's a problem that really divides up into two basic buckets. One is won't breathe, and the other is can't breathe. The won't breathe category are those that have primarily underlying problems that lead to ventilatory depression at the CNS level. This might occur in the setting of congenital hypoventilation syndromes, central hypoventilation syndromes. It might most commonly in adults occur when respiratory depressants are administered, such as opiates. And then there are metabolic causes for respiratory depression, namely hypothyroidism, metabolic alkalosis, and this disorder called leptin resistance, which is very common in patients with severe or morbid obesity. And then there are folks that really just can't breathe. They want to breathe, the output from the brain is sufficient, but they either have restrictive or obstructive problems. And I would include as obstructive diseases, obstructive sleep apnea, as well as intrathoracic airway obstruction, such as COPD, as in the blue bloaters, that tend to hypoventilate dramatically overnight when they go to sleep, and have REM-related, in particular, REM-related hypoxemia and hypercapnia. And so these are the so-called can't breathe type problems. We're going to focus primarily really on those who have more of the periodic breathing disturbances, repeated apneas that are more central than obstructive in nature. And in general, the final common pathway or the common ingredient in terms of pathogenesis of these disorders consists of a high loop gain. Now, we'll talk about three components of loop gain, but let's first describe or define what we mean by loop gain. Loop gain consists of the response in ventilation to any perturbation in ventilation that occurs. Now, the perturbation in ventilation that we oftentimes encounter in sleep disorder breathing patients is simply the transition from wakefulness to sleep. And when patients transition to sleep, ventilation tends to tail off. When they arouse from sleep, the reverse happens. Ventilation picks up. And the response to that change in ventilation that occurs with differences in sleep-wake state or transitions in sleep-wake state is vital for defining this entity called loop gain. And loop gain is literally the response in ventilation to any disturbance in ventilation that might hit the system. Now, when the loop gain is high, the tendency of the system is to oscillate or to develop a periodic breathing pattern. And we illustrate that here, where high loop gain can lead to ventilatory overshoot and then subsequently ventilatory undershoot, or a repeated pattern of respiratory instability. We'll illustrate that here with this sort of stylized graph of ventilation and PCO2. Now, if for whatever reason there's a stimulus to ventilation and ventilation picks up, as ventilation rises, the response to that increase in ventilation is a reduction in the PCO2. As CO2 falls, if it falls sufficiently, it will fall below what is called the apnea threshold, this dashed line here. And the distance between sort of eupnic CO2 levels and the apneic threshold, we will call the CO2 reserve. This is the buffer that prevents us from completely stopping breathing. But if that ventilatory overshoot is too great, we blow down our CO2 too much and we lose the drive to breathe, or in other words, develop a central apnea, as shown here. Now that central apnea lasts for some period of time, maybe 20 or 30 seconds. And as the CO2 rises once again, as it crosses that apnea threshold, ventilation is stimulated at the brainstem level and ventilation resumes. But just as sure as the ventilation resumes, we also find that you'll have oftentimes a ventilatory overshoot and the process repeats itself again and again. Well, the ratio of the response in ventilation to the stimulus, the minor perturbation in ventilation that might occur, for example, at sleep onset or offset, that ratio is the loop gain. And we'll break that down into three major components of loop gain that lead to ventilatory instability or an increased tendency to develop periodic breathing patterns. We illustrate that here as we look at the drop in CO2 that is required in order to lower the CO2 from a normal baseline level down below the apnea threshold. And that drop in CO2, as we've mentioned, is really related to the CO2 reserve, the buffer, if you will, that prevents us from stopping breathing altogether. But if the ventilatory overshoot is great enough, we blow down our PCO2 enough so as to cross below the apnea threshold and transiently stop breathing. It's there that respiration ceases and we develop a central apneic episode. Well, how do we look at the tendency to develop central sleep apnea? Well, in fact, as we've mentioned, the drop in CO2 leads to a decrease in the ventilatory response, and apnea ensues. Well, when does apnea ensue? And how do we know, or how do we predict when that occurs? And that really depends on the basic sort of relationship, which I will call, shown here, this is the isometabolic curve that relates the underlying level of CO2 to the level of ventilation. And as you might imagine, as you crank up your ventilation, say you hyperventilate, the CO2 is blown down. The unique aspect of this sort of isometabolic curve is that the curve is curvilinear. And the curvilinear nature of the curve is described by this basic equation, where the level of PCO2 is determined by the amount of CO2 that the body produces and needs to exhale, divided by the amount of alveolar ventilation in the denominator here. And because of the algebra of this expression defines a curvilinear relationship that we will refer to in a short period of time. Well, as you blow down the CO2, ventilation will decrease, and it will decrease more during wakefulness than during sleep. And so superimposed on this curve, what we see is that as we manipulate the CO2 exogenously, we generate a hypercapnic ventilatory response curve. Now, during wakefulness, this is a relatively steep curve where ventilation responds very steeply to minor changes or disturbances in the CO2. If we exercise, we produce more CO2. Well, indeed, our respiratory centers have a set point that adjusts our level of alveolar ventilation so as to maintain a eupnic CO2 set point. And that is shown here at this intersection here. When we go off to sleep, what happens is ventilatory depression occurs. The response to CO2 decreases a bit, and that's reflected by the drop in the slope of this CO2 ventilatory response, the orange curve, if you will, here. Going off to sleep leads to a small, modest rise in CO2 that accompanies a drop in ventilation. And as a result of that, what we see here is that the apnea threshold changes. During wakefulness, it's very hard to blow down your CO2 low enough that you actually stop breathing. And that's primarily because cortical centers provide a wakeful stimulus to breathe. When you go off to sleep, and in particular non-REM sleep, those cortical centers are no longer stimulating ventilation. And as a result of that, a minor drop in CO2 leads to a drop in the level of ventilation to the point that you actually stop breathing or have an apnea. And so we call that the apnea threshold, and the distance between eupnea, where we're meant to breathe in the steady state, and apnea is called the CO2 ventilatory reserve. Now let's look at that as we sort of pick apart three different factors that lead to an overall increase in loop gain. Now this is physiology, but the physiology maps exactly on the clinical presentation of the patients. And so if you'll bear with us, let's take a look sequentially at the impact of controller gain, plant gain, and circulatory delay. First, controller gain here. What is the impact of controller gain on our tendency to develop periodic breathing patterns or central sleep apnea? Well, shown here is a sort of normal situation where controller gain, if you will, is given by the slope of this CO2 ventilatory response curve. And where CO2 ventilatory response intersects our normal sort of CO2 production, we dial in a level of ventilation, about 5 liters per minute for most adults, that really represents the steady state position of ventilation so as to maintain a stable level of CO2. The controller gain, once again, is defined by the slope of this orange line, our response in ventilation to a change in CO2. Well, what happens if we go from sea level to high altitude? A drop in ambient oxygen tensions on the right-hand panel leads to an overall steepening of the CO2 ventilatory response curve. Well, as our sensitivity to minor changes in CO2 increases, what happens to our CO2 ventilatory reserve? It decreases dramatically. And that's shown here between the eupnic point and the apnea threshold. Compared to normoxia at sea level, Hypoxia drives an increase in ventilatory response, and we get closer and closer in our level of ventilation and CO2 to the point that minor perturbations lead to the cessation of breathing or central sleep apnea. And in fact, that's exactly what happens. And it's the reason that we see a high level of central sleep apnea when normal people go to high altitude into a hypoxic and become hypoxemic during ambient hypoxia. Now let's look at the other two mechanisms by which loop gain can increase our tendency to develop periodic breathing or central sleep apnea. Let's look at plant gain. What is plant gain? Well, plant gain is the efficiency with which each and every breath blows off our CO2. Here we have the steady state eugenic point here, shown by the dot on this diagram here. Plant gain is really represented by the inverse of the area subtended by this triangle. Well, let's say, for example, that we increase our ventilation. How effective is that increase in ventilation in lowering our PCO2? Well, that's determined here by the plant gain, how efficient we are in lowering the PCO2 with each and every breath that we take. And as we blow off CO2 efficiently, we drop the CO2 further and further towards the apnea threshold. Well, plant gain will vary depending on where we're located on this isometabolic curve. In other words, how much CO2 we're producing and how much ventilation we generate. Well, let's take the example of giving a patient opiates. We know that opiates represent they are a pharmacologic agent that depresses ventilation. Well, associated with the ventilatory depression, we move, when we take a hit of opiates, we move down the isometabolic curve. And so for the same level of CO2 sensitivity, represented here by the orange line here, the plant gain changes by virtue of the fact that this isometabolic curve is curvilinear. And so now minor increases in ventilation lead to major drops in CO2. And that's the effect of opiates or any respiratory or ventilatory depressant medication. The pharmacologic agents that depress ventilation lead to a marked increase in plant gain, meaning minor perturbations in ventilation lead to major excursions in CO2. And when we increase our ventilation by just a wee bit here, you can see by comparison to the normal situation, we blow down our CO2 just far enough that we hit the apnea threshold and we have a central apnea. And that happens repeatedly again and again as we rouse ourselves from a central apnea. We increase the level of ventilation. That level of ventilation leads to a ventilatory overshoot, and the ventilatory overshoot drops our CO2 once again as we slide off to sleep. It drops our CO2 once again down to the apnea threshold. And so the impact of opiates is really distinct from that of hypoxemia and controller gain. The impact of opiates is that it alters the plant gain, the response in CO2 to minimal changes in ventilation are greater when we've taken opiates than in the normal circumstances. Well, the final instance here, final factor, if you will, that increases overall loop gain really relates to circulatory delay, because circulatory delay leads to a mismatch between the response from the brain, ventilatory control centers in the brain, to any perturbation in ventilation. And we'll illustrate that here with a patient who has atrial fibrillation. You see evidence of atrial fibrillation by the irregularities in the heart rate here. But this is a typical Cheyne-Stokes pattern. And the Cheyne-Stokes pattern is often accompanied by an increase in the circulation time. The increase in circulation time is part and parcel of the pathogenesis of Cheyne-Stokes breathing. And it can be measured very easily on sleep studies by looking at the transit time that it takes for reoxygenated blood at the cessation of the apnea when ventilation occurs, resumes. At the resumption of ventilation here, how long does it take for oxygenated blood from the lungs to get through the heart and out to the finger oximeter? Well, normally that takes about 15 or 16 seconds. But in a patient with atrial fibrillation or possibly with cardiomyopathy, the circulation time is often prolonged, as it is in this patient. And it's that prolongation of circulation time that leads to the ventilatory control centers getting out of sync with the ventilatory requirements. And we see that here in this slide. If you focus on the left-hand panel, you can see that we're mapping out the CO2 concentrations in the lung, that's the red, and the CO2 concentrations that hit the brainstem ventilatory control centers in the blue. Well, when a patient has an apnea, during the apnea, the CO2 rises in the central circulation, but it takes a while for this rise in CO2 in the lungs to get out to the ventilatory control centers that really control the level of ventilation. As it does, it crosses above the apnea threshold and leads to a hyperventilatory response. But unfortunately, the ventilatory overshoot blows down the CO2 in the lungs. It blows it down so far that the CO2 in the lungs falls below the apnea threshold. But the CNS ventilatory control centers only see that reduction in CO2 quite a bit later. And it's because of that delay that the ventilatory control centers are essentially out of step with the CO2 concentrations in the central circulation. The analogy here is to the boy standing in the shower. When the temperature out of the shower head is either too hot or too cold, the immediate reaction is to flip the faucet, change the temperature by changing the amount of hot or cold water. But the circulatory delay, if you will, is represented by the length of tubing between the faucet and the shower head. And because the length of tubing or the circulatory delay is larger, the boy is more apt to over or undershoot as he adjusts the water temperature to minor perturbations in temperature. And the same thing happens with respect to ventilatory stability when we're faced with an alteration in ventilation that our brain responds to automatically, but responds to it too late. And it's as a result of that patients with heart failure or atrial fibrillation, they already start with heart failure, stimulation to ventilation, lowering their CO2 ventilatory reserve. But the circulatory delay on top of that leads to the over and undershoot as the mismatch occurs between ventilatory control and the ventilatory requirements that lead to hyperventilation as patients cross the apnea threshold, or hypoventilation as they go off to sleep and no longer have the need to breathe during a central apnea. Well, let's look at the clinical impact of these problems in terms of central sleep apnea and Cheyne-Stokes breathing patterns. And that's really represented here, where the Cheyne-Stokes respiration in central sleep apnea leads to poor sleep quality and intermittent hypoxia. Now, as a result of that, we have with hypoxia and intermittent arousals, there is a toll on the heart and the cardiovascular system represented by low oxygen, ischemia, and systemic inflammation. The reaction is with repeated arousals, a jolt of sympathetic activity, a surge of adrenaline during the arousal phase that lead to even greater cardiovascular stress. And with that arousal phase, as we've mentioned already, the arousal itself jazzes up our loop gain and leads to the ventilatory overshoot that sets up the conditions for the next apnea, central apnea or hypopnea. Well, the sleep fragmentation leads to daytime fatigue, frank insomnia, sleepiness, and personality changes as well as poor concentration. But nocturnally, what we find is, in addition to sleep disruption, patients often arouse with a gasp or a choke, sometimes with fluid mobilization to the central circulation, paroxysmal nocturnal dyspnea, morning headache, or nocturnal angina or arrhythmia. And the overall problems that we've mentioned physiologically really compound the problems of pump stress that results from an increase in sympathetic activity, cardiac remodeling, and ultimately accelerated ventricular dysfunction. And it's as a result of that that really we see in this patient population with Cheyne-Stokes and central sleep apnea, increased hospitalizations and increased mortality. And the latter is shown here, where apnea of all sorts, but particularly central sleep apnea and Cheyne-Stokes breathing, shown here in the red survival curve, shows that those with Cheyne-Stokes and central sleep apnea and a reduction in left ventricular ejection fraction have markedly reduced survival over the 24 to 36 month period compared to matched controls with minimal to no sleep disorder breathing patterns. And so this is really a very significant problem, and it's one that really merits recognition on sleep studies. And we'll focus on that simply by highlighting at the 20,000-foot view the differences that you can see on your sleep studies between an obstructive patient and a central patient. Obstructive episodes, by and large, are generally characterized by snoring and by some degree of persistence or worsening during REM sleep. And I highlight that with this compressed, sort of all-night view of the physiology on a nocturnal sleep study, where we see the snore signal is represented in decibels in the orange trace, and you can see that there's abundant snoring throughout the night. But in addition, if you look at the REM periods here, three out of four of these REM periods are associated with worsening hypoxemia. In other words, if anything, apnea does not get better during REM sleep. It persists or generally gets worse. Now, I contrast the snoring and the REM predisposition to apnea in a patient with obstructive apnea to that of a patient with central apnea and Cheyne-Stokes breathing. And that's really shown here, where we see a paucity of snoring, the orange tracing here, and during the REM periods, what do we see? Much less intermittent hypoxia. In fact, the apnea goes away almost completely with an AHI of 7.2 during REM sleep in this Cheyne-Stokes patient versus an AHI of 46.9 during non-REM sleep. The intermittent hypoxia during non-REM sleep is abundantly clear as you see the fine desaturations. At the moment the patient hits REM sleep, the desats go away and respiratory stability ensues. And so it's the loss of snoring, lack of snoring, and the stabilization of the breathing patterns, particularly during REM sleep, that provide us with an early indicator just from the report itself that we're dealing with a patient who has predominantly Cheyne-Stokes breathing and central sleep apnea. Now, if you drill down further, you can see even more evidence in the recording itself, because the obstructive episode is really characterized by an abrupt asymmetric pattern that we see. Remind you of the fact that in nasal airflow, airflow ceases, but obstructive breaths continue here. The respiratory effort shows an augmenting response to the upper airway obstruction. And with that response, increasing degrees of asphyxia increase the ventilatory drive, and we see that increase in ventilatory drive with the increase in respiratory effort. But the airway is occluded, so we're not generating any ventilation. Well, all of that changes abruptly when the airway reopens. And so with reopening of the airway, suddenly there's an inrush of air into the lungs. And it's that abrupt increase in ventilation from zero, if you will, before the arousal to sudden resumption of ventilation exactly at the arousal that leads to an immediate resaturation. The resaturation is often much steeper than the preceding desaturation. The desaturation is blunted, if you will, because at the onset of the apnea, when the airway occludes, there's still oxygenated air that remains in the lung. And because there's oxygen trapped in the lungs behind the obstruction, in fact, there's a gradual decrease in oxygen saturation, but with the arousal after asphyxic drive increases, an abrupt increase. This is a highly asymmetric pattern. What I would do is contrast that to the Cheyne-Stokes central apnea patient, where the patterns are much, much more symmetric or sinusoidal. Why? Because there's, generally speaking, not airway obstruction and no buildup of ventilatory drive. Instead, ventilatory drive builds gradually in a sort of waxing and waning or sinusoidal pattern. And it's that waxing and waning of ventilation during the hyperpnea phase that leads to a much more symmetrical change in all of the cardiorespiratory signals, whether it be the effort, the airflow, or the oxygen saturation. And it's because of that that we really can recognize on sleep studies, when we look at the recordings, three distinct patterns that suggest an underlying central sleep apnea diathesis. We've spoken about heart failure and atrial fibrillation, where ventilation, if you will, often waxes and wanes. And when it wanes, we see the central apnea, the absence of respiratory effort. But this is really the purely sinusoidal pattern, completely symmetric. We also see a very, very symmetric pattern in people who have cluster breathing, oftentimes on opiates. And the cluster breathing pattern is one of abrupt start-stopping of ventilation. This is characteristic of patients who might be on moderate to high doses of methadone, where you see at the moment they go off to sleep, they begin these very short central apneas, punctuated by 2 or 3 resuscitative breaths, but the breaths are more or less symmetric. There's not that sort of sudden increase in ventilation at the start of the arousal phase, but rather abrupt breaths or ventilation that lead to a much more symmetrical cardiopulmonary signal pattern. And you see the symmetry here in oximetry, you see the symmetry in the ventilation, but you see it, for that matter, in pulse rate and any other cardiorespiratory signal. The challenge here comes in the lower right-hand panel, where you see a mixed event, a central apnea, a central component, followed by a few obstructed breaths. And the presence of those obstructive breaths leads to the ventilatory overshoot and an asymmetric pattern. And so generally speaking, obstructive episodes And mixed episodes lead to the abrupt resaturation compared to the preceding desaturation. So you've got abundant clues of central diathesis on the sleep study, on the report itself, where we see in central sleep apnea REM predominance, but also relatively little snoring. And then to confirm on the reporting, on the recording itself, we're looking at the degree of symmetry that we see with the central types of sleep apnea characterized by sinusoidal sinusoidal fluctuations or symmetric fluctuations in all of the cardiopulmonary signals. In the Cheyne-Stokes patterns, we oftentimes see a prolongation of circulation time, evidence of atrial fibrillation, and clinically, history of cardiomyopathy or volume overload. And the arousal phase tends to be after the onset of ventilation after apnea termination. Well, let's look at therapeutic approaches, because it turns out our recognition of these patterns and our understanding of the underlying pathogenesis of these patterns really leads us directly to specific therapeutic approaches. And I would really highlight those, again, thinking pathophysiologically in 4 buckets of activity, where we're making therapeutic decisions based on what we understand the underlying pathogenesis of the disorder is. Well, first and foremost, in those who have circulatory feedback delay, primarily our Cheyne-Stokes breathing patterns, we want to make sure that we've optimized volume status and heart failure management in general. Volume status, needless to say, involves diuresis. Heart failure management is a variety of pharmacotherapy which really optimizes afterload, contractility, and other factors that really optimize cardiovascular function. And so I would really emphasize the fact that attending to the heart initially is really first and foremost our most important therapeutic intervention, oftentimes in collaboration with specialists in the area. From there, though, I would go on to say that really we can address specific pathogenic mechanisms in part by looking at identifying the mechanism and looking at the potential for intervention. Plant gain. How do we intervene with plant gain? Well, acetazolamide is probably the best opportunity that we have. And what this does is it really essentially, and I apologize for these slides that are getting a little bit jumbled up with respect to the words, we see here our isometabolic curve against CO2, ventilation versus CO2. What acetazolamide does is it shifts the overall eupnic point on this isometabolic curve. It induces a slight metabolic acidosis, and with that, the CO2 goes down. As CO2 goes down, ventilation goes up a wee bit, but what does that do? It decreases the plant gain. It decreases the efficiency with which ventilation blows down our CO2. And so it takes more ventilation. With acetazolamide, it takes more ventilation to blow down our CO2 all the way down to the apnea threshold. And it's for that reason that acetazolamide might take its place, particularly with hypercapnic patients, but in patients in whom we're trying to temporize and decrease the plant gain mechanism by which loop gain increases and central sleep apnea ensues. Now, the response to acetazolamide is generally somewhat favorable, but it taps out at about 500 milligrams. Daily dose is shown here at the y-axis. The effect size is shown here as a standardized effect size on the x-axis. The improvement, a downward shift, occurs and pretty much taps out at about the 500 milligram per day dose. I tend to start low at 125 to 250 milligrams, and only increase in larger individuals who have a higher BMI. But this can temporize and can result in some improvement in central sleep apnea. Controller gain is represented really by the effects of oxygen on the CO2 ventilatory response curve. And we commented that if we can decrease the sensitivity of the ventilatory response centers by oxygenating or reoxygenating our patients, we can perhaps mitigate central sleep apnea. Now that can be done with supplemental oxygen, but is perhaps best illustrated in the CANPAP trial. CANPAP trial was done about 15 or 20 years ago, in which patients with heart failure and reduced ejection fraction in LVEF of 25% who had concomitant Cheyne-Stokes breathing, rather severe, 40 episodes an hour of central sleep apnea, were randomized to either CPAP or usual care. 2 years of follow-up, sleep disorder breathing metrics are represented in general in these slides here on the right-hand side. And what we see is that CPAP is a partial palliative. It takes the apnea frequency down from about 40 an hour down to about 20 an hour. It improves nocturnal oxygen saturations. You even see a little bit of a bump in the left ventricular ejection fraction and in other oxygen indices over the course of the night. The issue here is that CANPAP or CPAP alone is not a home run. It does decrease the apnea frequency by a considerable extent, but it was demonstrated not to improve or impact whatsoever on cardiovascular morbidity or mortality. And so as a result of that, we're really left with bilevel ventilation or phrenic nerve stimulation, where we're really substituting ventilatory assistance to fill in the gaps shown here by the central apneas here, punctuated by the hyperpnic responses. Adaptive servoventilation came about in the early 2000s. It was thought to be the best thing since sliced bread. It varies the level of BiPAP using smarts underneath the hood of a bilevel device and varies the amount of ventilatory support or pressure support that is applied during the central apneas to replace the absence of ventilation with extra pressure support or ventilatory support. The problem that we have here is that ASV, it's a complicated modality. We won't go into it so much here, but ASV, unfortunately, in those with reduced ejection fraction, ASV resulted in an increased mortality. And what we're seeing here in the bottom for the SERVE-HF trial, patients with HFrEF, heart failure with reduced ejection fraction, were randomized to ASV versus control. And we see here that the primary endpoint was all-cause mortality. Here in the middle panel, the primary endpoint, meaning a composite endpoint for all cardiovascular and other causes, both of them showed worsening survival, worse mortality in the ASV intervention group compared to controls. And death from cardiovascular causes paralleled, meaning ASV unfortunately did not impact in a positive way. Rather, it was a negative factor that led to increased cardiovascular morbidity and mortality, death from any cause, and worsening composite endpoints, whether it be death, time to an acute life-saving intervention, or time to an event such as heart failure, transplant, etc. All of this really suggests that ASV is off the table, particularly for those with heart failure and reduced ejection fraction below 45%. As a result of that, we turn really to the final modality, which is phrenic nerve stimulation. Now, phrenic nerve stimulation is a method for pacing the phrenic nerve. It is indicated for those who have moderate to severe central sleep apnea, adults with moderate to severe central sleep apnea, the only contraindication is active infection, which would preclude implantation of a phrenic nerve pacing device. We'll see the contours of that device here. It's shown here diagrammatically on the left side. It is a fully implantable pacemaker system. It's designed to treat moderate to severe central sleep apnea and Cheyne-Stokes breathing. It activates the phrenic nerve, and there are three components: a pulse generator, a pacemaker can, if you will, that's implanted in the usual place below the clavicle. The stimulation lead is passed transvenously, either to the left pericardial phrenic vein or to the right brachiocephalic, in close proximity through the venous wall to the phrenic nerve on either side. And a sensing lead is optional, but does help to identify the exact stimulation frequency that leads, or intensity, that leads to an optimization of diaphragmatic capture and stabilization of ventilation. Another important feature of this implantable system is that it turns on automatically at night. The automaticity of this device is one of the things that ensures and drives therapeutic compliance. You literally just simply set the pitch level, the level of inclination that the patient usually sleeps at, and the usual sleep window, 11 p.m., for example, to 7 a.m. And shown here is a representative recording of a patient who is lying recumbent during that sleep window. Well, after observing for a couple of minutes, a typical Cheyne-Stokes pattern shown here in the airflow and respiratory belts on the left-hand side, the ventilator, the pacemaker automatically kicks in. And as it does, it senses that it's captured ventilation, and you see that here with an overall stabilization of airflow and belt patterns here. The respiratory patterns stabilize. But it goes one step further. It actually increases automatically the intensity of stimulation to further capture in a reproducible and predictable fashion the ventilatory patterns and stabilize the breathing patterns. Well, that's great, but the moment the patient rouses and goes upright, has Cheyne-Stokes patterns again, at that point, it times out until another couple minutes elapse, and then it kicks in once again automatically. So it allows the patient to get up to use the restroom, but go back to bed, and then within a few minutes, it kicks in and automatically adjusts the intensity of stimulation so as to stabilize the respiratory patterns, as you see here in the middle portion of this panel. Well, the evidence for that really resulted from a pivotal randomized controlled trial. And that trial randomized patients to active therapy versus control. The randomized portion lasted 6 months, and then all patients were followed. Control patients were turned on, their stimulator was turned on, and they were followed. All patients were followed for safety endpoints. What we find here is that over a course of 5 years, the AHI goes down dramatically from rather high levels in the high 30s down to roughly 10 episodes per hour. Very comparable, if you will, to the INSPIRE results for hypoglossal stimulation in OSA patients. But you can also drill down to these data, and you can see that the phrenic nerve pacing system, the remedē system, is effective particularly in taking care of or getting rid of, if you will, the central apneic episodes, with the remaining obstructive apneas sort of persisting as a background level. No matter how we've sliced and diced this patient population, the results, the responses in central sleep apnea and Cheyne-Stokes breathing to the remedē system are durable over a 5 or more year period. And it's as a result of the durability that we see a marked reduction in Epworth Sleepiness Score, improvements in a global quality of life assessment in the treatment compared to the control group, and suffice it to say that adverse events were minimal and relatively limited. No deaths whatsoever. So what I'd like to do is I'd like to really just summarize and conclude that central sleep apnea is a form of periodic breathing that can be attributed to increases in loop gain. But we know that there are three main causes for increased loop gain. Controller gain is often the result of ambient hypoxia or hypoxemia in patients with underlying cardiopulmonary disease. Increases in plant gain often occur in patients who are on CNS ventilatory depressants, or in those who have hypoventilation syndromes, in whom the eugenic point is shifted over on the isometabolic curve to the right and leads to really a marked increase in plant gain and brings us preciously close to the apneic threshold. And the final cause is an increase in circulation time that occurs often in heart failure or patients with really chamber enlargement. You might not have heart failure, but you might have atrial fibrillation with a dilated left atrium. And those patients also have an increased circulation time that leads primarily to a Cheyne-Stokes and central sleep apnea breathing pattern. We've seen that in heart failure, the Cheyne-Stokes breathing pattern is associated with increased cardiovascular morbidity and mortality. And that if we keep in mind, finally, these three buckets of different, discrete, different pathogenic mechanisms for central sleep apnea and Cheyne-Stokes breathing, we can mitigate the specific mechanisms by either treating the heart failure, improving the oxygenation, or stabilizing the ventilation, as we've shown in the appropriate patient with either ASV or with the remedē phrenic nerve stimulating system. So I'll conclude there and perhaps stop for a few minutes. If anyone has any questions, I'd be happy to chat.
Thank you, Dr. Schwartz. Yes, if anyone has any questions, please feel free to put them in the Q&A. So thank you, Dr. Schwartz. That was an excellent talk. So are you, is there any tips as how you can, or information on how to identify hypopneas or classify hypopneas between obstructive and central that you can additionally add for folks?
Yeah, absolutely. The first thing I would do is I'd highlight the differences between central patterns and obstructive patterns on the report itself. And we spoke about the presence of snoring and the relative differences in the severity of the AHI between non-REM and REM sleep. And those are really our initial flags on the report. The other flags might be the clinical constellation of signs and symptoms, those that relate to the presence of atrial fibrillation or heart failure, or perhaps recognized underlying cardiopulmonary disease, CO2 retention, or they happen to be on opiates or other ventilatory depressants. These are all clues that you get either from the clinical history or from the report. Then you can drill down into the recording itself. And I would really highlight the fact that the obstructive episodes are really very different from the central episodes. They're different in the overall asymmetry that you see in obstructive episodes, whereas you see relative symmetry in all of the cardiorespiratory signals in patients with central sleep apnea, whether they happen to be apneic episodes or hypopneic episodes, it really doesn't matter. Look at your oximetry in particular, and you'll see that there's more or less a sinusoidal waxing and waning of the oximetry that occurs across the spectrum of central sleep apnea syndromes. And then finally, as you look in greater detail at the airflow and the effort patterns, there are many clues. The effort tends to be characterized by thoracoabdominal paradoxing during the obstructive episodes. whereas the central hypopnea is more characterized by the absence of paradoxing and symmetric increases in waxing and waning with respiratory efforts in both signals that are in synchrony with one another. You don't tend to see the crescendo increase prior to the arousal in these effort signals. And then finally, you can drill down into your airflow signal, in particular the nasal cannula, and you can find the patterns that really are characteristic of folks that have so-called inspiratory flow limitation. Inspiratory flow limitation essentially means that flow during inspiration plateaus despite the fact that respiratory effort continues to increase. When you see that plateau in flow within a breath or among a series of breaths, as the flow plateaus over a series of breaths, but the effort continues to increase, you know you've got an obstructive airway. When you see a concordance there, on the other hand, between the flow and the effort, as the flow and the effort go hand in hand, in synchrony with one another, you can be sure that you're dealing with central apneas or hypopneas. And so I would really encourage you to think of your central apneas. The same features are recapitulated on your central hypopneas.
All right, excellent, thank you. We got quite a few questions popping up, so we'll take time. We're at time, but we'll have time for a couple more. Can BiPAP ST mode help for patients with CHF and OSA?
So BiPAP ST mode is not typically our first stop for OSA, unless the OSA patient on CPAP or on an APAP device develops treatment emergent central sleep apnea. And so very frequently your patient with heart failure who you believe to have predominantly obstructive sleep apnea in the baseline study, as you titrate the CPAP or an automated device titrates the CPAP automatically, you find that patients come back to the office with residual apnea on CPAP or on an APAP machine. It's under those circumstances that I'm looking very closely at whether the residual events are central rather than obstructive in nature. If there's central events, then I've got to ask myself the next question. Is the LV ejection fraction below 45% or not? If it's below 45%, then I'm not using a BiPAP machine at all, whether it be ST mode or ASV. If it's above 45%, you've got the flexibility to give the bi-level device in whatever mode you choose. You have the flexibility to give the bi-level device a try. But below 45%, bi-level devices are essentially off the table. And that shoots me in the direction of a remedē or phrenic nerve pacing system, primarily to impact on the central sleep apnea, the sleep quality, the quality of life. And ultimately, what we've seen in the pilot data is that there has not been a morbidity or mortality signal. In other words, left ventricular ejection fraction, if anything, improves on the remedē, and we're not seeing the mortality signal that we saw in the SERVE-HF trial with the ASV ventilator.
Great, thank you. Maybe Dr. Schwartz, I can send you the questions. There's quite a few questions and we're over time. So thank you all for joining us, and reach out to me if you, a couple of these questions were anonymous. So reach out to me if you'd like your question answered. Dr. Schwartz is excellent at responding with questions, but I want to be respectful of everyone's time. So thank you for joining, and thank you again, Dr. Schwartz, for taking the time to educate us all. Appreciate it.
You bet. You bet. Thank you.
Bye.
Bye now.